Good afternoon and happy Halloween, everyone. I am Amy Hajari Case. I'm a senior medical advisor at the Pulmonary Fibrosis Foundation, and I am just very excited to welcome you all to our industry-sponsored webinar presented by United Therapeutics and the Pulmonary Fibrosis Foundation. We have a very timely topic for today. It's pulmonary hypertension associated with interstitial lung disease and how it is diagnosed. This is very timely as the Pulmonary Fibrosis Foundation and the Pulmonary Hypertension Association actually just released a joint position statement on this very topic last week, and that is available on the Pulmonary Fibrosis Foundation's website if anybody's interested in looking that up at some point. So we'll get started. First of all, I would like to introduce our wonderful speakers for today. Dr. Hyein Kim, she is the director of the Interstitial Lung Disease Program and supervises ILD clinical trials at the University of Minnesota's ILD program. She established their ILD database in 2010 in order to answer questions about the natural history and outcomes of ILD. Her clinical expertise centers really on treating patients with interstitial lung disease, and her research interests include the natural history and outcomes in idiopathic pulmonary fibrosis, pharmacogenomics of the antifibrotic medications, non-pharmacologic treatments for ILDs, and clinical trials in interstitial lung disease. Also, we have with us Dr. Thenapin. He is a cardiologist who treats conditions with heart failure, pulmonary hypertension, and a multitude of other heart-related conditions. He sees patients at the University of Minnesota's Health Heart Care, Minneapolis, in the clinics and surgery center. His clinical interests include mechanical circulatory support, pulmonary vascular disease, and right heart failure. And in addition, he's an associate professor of medicine for the cardiovascular division of the University of Minnesota Medical School. So I would just like to welcome you both and thank you both for being here. Before we get started, I'll briefly show our, all of our relevant disclosures here for this topic. And just a couple of housekeeping items. First of all, our medical disclaimer, we are providing information and education here, and this is not a substitute for professional medical advice. We will not be able to answer specific medical questions about your particular medical condition. But we are excited to answer your questions about pulmonary hypertension related to ILD. So if you will go to your GoToWebinar control panel, mine is on the right side of my screen, yours probably is too, and look down the line there. There is a little tab that says questions and an arrow next to it. If you click down on that arrow, you should be able to type in any questions along the way that come up that you would like to hear answered, and we will answer as many of them as we can at the end of our session today. And then if you'll go down just a bit more, there is a chat box there, and you can click the arrow next to that. If you are having any technical issues or any trouble with the webinar platform, please type any of your questions there, and somebody from our team will try to address those with you in that chat box. Okay, so before I use all of our time for today, I will turn this over first to Dr. Hyein Kim. Thank you so much for being here, and let's get started.
Thank you. I just want to thank Dr. Case and Dr. Thenapin for doing this joint webinar. And first of all, I apologize for my office. It's a disaster, but I couldn't figure out how to blur the background. We're going to be talking about PH-ILD, or pulmonary hypertension associated with interstitial lung disease. My area of interest is in ILD, so I'll focus on the first part of this webinar in interstitial lung disease. So we'll talk a little bit about lung function, about what is interstitial lung disease, and then we'll hand it over to Dr. Thenapin to talk about pulmonary hypertension. Next slide, please. So how do healthy lungs function? You know, what I tell my patients is that I'm going to start off by giving them a brief anatomy lesson of the lungs. So we think of the lungs like an upside down tree. The windpipe is the trunk, and the windpipe or the trachea is the trunk of the tree. Air flows down through the windpipe or the trunk and then follows the branches. And if you think of about a tree trunk upside down, the trunk branches and those branches branch until you get to the very, very small branches or twigs. And that's how the lungs function. You have the windpipe that branch to the left lung and the right lung, and those branches continue to branch to the very, very small twigs, which are the very small airways. And at the ends of the twigs are the leaves or the alveoli, the air sacs. And the air sacs is where the most important part of the lung function occurs. Air travels through the windpipe, the branches, to the twigs, to the air sacs or alveoli. It's in the alveoli that the oxygen from the air gets absorbed through the lungs into the bloodstream, and then the blood goes to the heart and the heart pumps it out to the body. So that's how our body gets oxygen. Next slide, please. This is a schematic of that. If you notice at the bottom of the diagram, it's the heart, right? So if you'll notice, blood from the body comes from the body to the heart, comes to the right side of the heart. The right side of the heart then pumps that body, and you follow the arrows, it says blood to the lungs. The heart pumps that blood to the lungs. The lungs then take the blood from the body. It oxygenates that blood by absorbing the oxygen, absorbing it into the bloodstream. The blood absorbs the oxygen. The oxygen and the blood then goes back to the heart, and the blood gets pumped by the left side of the heart to the body. So the lungs and the heart work very closely together, and it's the job of the lungs to absorb the oxygen so that the heart can pump that oxygenated blood to the body so the body can function. This is a cycle, and it occurs every time the heart pumps, which is our pulse. When we talk about pulmonary hypertension, it affects the heart and the lungs, and it affects the ability of the lungs to absorb the oxygen so that less oxygen gets absorbed and less oxygen is then transported to the body. So this is what we call the pulmonary circulation. This is that whole system of arteries and veins that connect the heart and the lungs, and the heart and lungs then work together to absorb the oxygen and then transport it to the body. Next slide, please. So what is interstitial lung disease? So next slide, please. Interstitial lung disease is a category. It's not one disease, but it's a category of many, many diseases. And the hallmark of interstitial lung disease is that the lungs are affected by inflammation and or scarring. Scarring of the lungs is pulmonary fibrosis. So one of the other ways to describe interstitial lung disease is diffuse parenchymal lung disease. What we should know about interstitial lung disease is that these processes can affect any portion of the lungs. It can affect those branches or airways. It can affect the leaves or air sacs, and then it can affect the structure, the integrity, the building blocks of the lung that provide the structure to keep the lungs open. So these are diffuse diseases that can affect any portion of the lungs. And the reason interstitial lung disease is complex and can be complicated is that there are hundreds of different types of interstitial lung diseases. Next slide, please. So how does interstitial lung disease affect the lungs? So we talked about the normal function of the lungs. The lungs are really important because that's where oxygen gets absorbed into the blood, and then the heart pumps the blood to the body. In interstitial lung disease with inflammation and scarring or pulmonary fibrosis, that scar tissue and inflammation can block absorption of the lungs. It's sort of like if you have a thin film, between the air and the blood, that thin film is the interstitium. And oxygen is able to diffuse and travel through that thin film or interstitium from the air into the blood, and it travels very easily. However, in interstitial lung disease, inflammation and fibrosis will increase that barrier. So it's almost like you're putting cement into that thin film and widening that film or interstitium. So by causing increased depth of the interstitium, increased scarring, it takes longer for oxygen to pass through the lung from the air into the blood. And that's why it's so difficult for some people with interstitial lung disease to get the oxygen that they need. It can make it difficult for supplemental oxygen or oxygen therapy to correct that, especially with exertion. And many people with interstitial lung disease find that their shortness of breath is exacerbated or worsened with activity, either regular daily activity or with exertion and exercise. And that's because it takes longer for the oxygen to travel through that barrier. Instead of a thin barrier, now that barrier has been thickened by inflammation and scarring. So that is why many people with interstitial lung disease feel short of breath, especially with activity, with movement, with exercise. Next slide, please. So as I mentioned, there are hundreds of different interstitial lung diseases, and many people say that there are probably over 200, the most common being IPF. I will say that interstitial lung diseases, although there are hundreds of them and they're complex, we try to simplify it a little bit for providers and patients and families by grouping interstitial lung diseases into categories. So you can see in this schematic that we group ILDs into 3 large groups. I'm going to start with, on your right-hand side, the exposure group. So many interstitial lung diseases are associated with an exposure. And by that we mean an exposure that you breathe in. This is not something you can get by touching something with your skin. It's something that you breathe in. And these exposures can be occupational or environmental. So in someone's occupation, for example, construction workers, where they're exposed potentially to silica or asbestos fibers, or farmers who are exposed to moldy hay spores. So many of the interstitial lung diseases can be caused by inhalation of particles from your environment. So that is a large group of interstitial lung diseases. By exposure, we also talk about drugs. And in this category are medications used to treat various medical conditions, including heart disease. In this category, I also place chemotherapy and radiation therapy. So this is a very large group of interstitial lung diseases. We make the diagnosis really by talking with our patients about what medications are you taking? Have you ever been exposed to chemotherapy or radiation therapy? What kind of occupation do you practice? What are your hobbies? Is there any mold in your environment, either at home or at work? And so we ask sort of a brief exposure questionnaire. So the second large group of interstitial lung diseases are autoimmune related. These are connective tissue diseases. And you can see the list here. It includes sarcoidosis, rheumatoid arthritis, Sjogren's, lupus, scleroderma, and myositis. So we do know that any type of autoimmune disease is associated with risk of developing interstitial lung disease. So whether you have scleroderma or antisynthetase syndrome or rheumatoid arthritis, we know that all these autoimmune processes can affect the lungs. And so this large group of lung diseases or interstitial lung diseases are treated a little differently from the others because they are associated more with an autoimmune process and associated with more inflammation in the lungs. So this is a very large group. And what I tell my trainees and my patients is, if you have an autoimmune process, it's important to think about lung involvement and whether your lungs are being affected by the autoimmune process. Many of our providers either miss out or sometimes not miss out, but sometimes they don't think about the autoimmune process in relation to lung disease because they might be more focused on the joints or arthritis or the skin and rashes or the muscles and weakness. But it's very important to realize that any autoimmune disease can affect the lungs. Okay, and then the last large group is what we call the idiopathic group. These are the idiopathic interstitial pneumonias. It's sort of an alphabet soup. Idiopathic pulmonary fibrosis, idiopathic nonspecific interstitial pneumonia, respiratory bronchiolitis, ILD, desquamative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. I think it's important to realize that even though this is a group called pneumonias, this is not an infection. This is not something you get when you get the flu or a cold or an infection. Doesn't need to be treated with antibiotics. The pneumonia really is a pathologic description of what's going on in the lungs. So it's important to realize that the idiopathic interstitial pneumonias are not an infection. It's the process in the lungs that causes inflammation and fibrosis. So this category is termed idiopathic because many of these interstitial lung diseases are of unknown cause. So by that, we mean there's no exposure, there's no medication, there's no occupation, there's no environmental mold, and there's no underlying autoimmunity. So these are idiopathic. Many times when we see patients who have interstitial lung disease, we do an extensive evaluation to try and figure out the cause, because depending on the cause, that can determine treatment. But these types of interstitial lung disease have no known cause. They differ in terms of the extent of inflammation and or fibrosis in the lungs. And so they look a little bit different on the CAT scan of the lungs, and they look a little bit different on lung biopsies if we get a lung biopsy. And the way we diagnose this is with a combination of what patients tell us. We rule out everything else. We look at the CAT scan, and if there's a lung biopsy, we look at the lung biopsy. So we make this diagnosis of idiopathic by ruling out every other cause, and then we determine the pattern. The pattern can be very important, like I said, in showing us or sort of directing us on which pathway we should be going for treatment. In the category of idiopathic interstitial pneumonias is IPF, idiopathic pulmonary fibrosis. It's one of, if not the most common type of interstitial lung disease. We probably know the most about it. There's been a lot of research in IPF in the past 30, 40, 50 years. And I would say there have been very exciting advances in the scientific realm, but also in the clinical realm in terms of treatments for IPF, and a lot of ongoing work directed towards better treatments for IPF and all the interstitial lung diseases. Next. Next slide, please. So what causes ILD? This is a really good question. We get asked this a lot from patients, from families, from providers, from trainees. As you can see on this schematic, there can be many causes, as we talked about in the environment. So the exposure, if there's an exposure in the environment, can be organic or inorganic. So inorganic particles that we breathe in can be asbestos, silica, hard metals, like people who work in metal factories or machine shops, and coal dust. You know, we all are very aware of the occupational hazards of coal mining. The organic particles are, I think, a little less known by the general public. The organic particles that we breathe in come from animals. For example, birds. The mold is a huge exposure. So by mold, you know, mold grows in sort of damp places, whether it's bathrooms or kitchens or around windows or in the drywall. The mold releases spores and we breathe in the spores. That's why mold is such a huge culprit for interstitial lung disease. There are certain bacteria also that we inhale, and by the inhalation, it's not causing a pneumonia, it's causing actually interstitial lung disease. And then we mentioned farmers. Hay is an important exposure because of the mold spores that can grow in the hay. Smoking, we do know that smoking is a big risk factor for interstitial lung disease, especially IPF. It's a known association that most people with IPF have been smokers or are current smokers. So like many things associated with smoking, interstitial lung disease is one of the consequences. We talked about connective tissue disease, which is autoimmunity, and how that autoimmunity can affect the lungs, initially causing inflammation that turns into, or can turn into, fibrosis or scarring of the lungs. And then drugs. These are just 4 of the more common drugs that we talk about. Nitrofurantoin is an antibiotic used to treat bladder infections, for example. It's still used. It's not a common consequence of using nitrofurantoin, but we're all very cognizant of this, and it's one of the drugs we think about. Amiodarone, which Dr. Thenopin is very well aware of. It's a cardiology drug used to treat some abnormal rhythms in the heart. Methotrexate is a medication used to treat arthritis and different types of arthritis, and then of course chemotherapy. I just want to say this is a really nice schematic because it talks about what causes ILD, the associations, the risks. This is sort of a brief summary. There are hundreds of other exposures that are just too many to list. But your doctors will go over this with you and make sure that they will look at all different possible causes. The reason this is important is if we can identify a cause, then we try to eliminate that cause. And eliminating the cause of the ILD could be helpful in therapy and in prognosis. Next slide, please. And that is my portion of the webinar. Thank you.
Yeah, thank you, Dr. Kim. I'll take over from there. First of all, I want to thank the organizers and Dr. Kim and Dr. Case, and United Therapeutics and the Fibrosis Foundation for having me. It's a pleasure and honor to share our knowledge and discuss with patients. Dr. Kim gave a beautiful overview of what is interstitial lung disease, and now I'm going to focus more on the pulmonary hypertension part. So what is pulmonary hypertension? Next slide, please. Pulmonary hypertension is a condition that affects the blood vessels in the lungs. So as Dr. Kim went over the anatomy of the lungs, I will briefly go over how the normal anatomy of the heart and the lung works together. When I see a patient and explain to them, this is how I normally explain, that all of us have, like, the blood in our body has to get oxygen for us to, for our cells to work. So the used blood, I call, from the body will drain through the veins into the right side of your heart. From the right side, it's a pump. The right side of the heart pumps that blood into the lungs through blood vessels. So these are like pipes which carry the blood from the right side of the heart and into the lungs. So like Dr. Kim mentioned, like the lungs are like trees. So in the trees, there is a main branch, and then there are like 2 big side branches, and then that divides into smaller branches. The blood vessel also follows the same pattern. There's one big blood vessel that takes the blood from the right side of the heart into the lungs. It divides into two branches and goes into two lungs. And then in the lungs, it follows the branching pattern of the lung tissue and divides into small twigs, like in a tree. So the used blood from the right side of the heart is pumped by the heart into the lungs. And when the blood goes through the lungs, we breathe in oxygen and we get oxygen in. That oxygenated blood, or the pure blood, then drains into the left side of the heart. And then the left side then pumps the blood into the body. That's how normal circulation works. So normally the pressure in the blood vessels that carry the blood in the lungs is very low. It's like if you assume a kitchen sink and there's no blockage, water can drain easily. So like that, normal blood vessels are nice and wide, circular, open pipes, and blood can flow easily and there is no pressure. However, in pulmonary hypertension, what happens is the pressure of the blood that's flowing inside these blood vessels is high. And normal pressure in our lung arteries is 20/10. Compared to your regular blood pressure in your body, the regular blood pressure, normal pressure, we say is 120/80. So the pressure in the lung arteries are 20/10. So that means it's really only 1/6 of your regular pressure in your body. So it's a low pressure system. But when that pressure in the lung arteries goes up high, that is called pulmonary hypertension. Next slide, please. So what happens in pulmonary hypertension? Why does the blood pressure in the blood arteries in the lungs go up high? So in people who don't have pulmonary hypertension, the blood vessels in the lungs are open and wide, and it allows the blood to pass through easily, like a normal kitchen sink. However, when you have pulmonary hypertension, or when a patient has pulmonary hypertension, the blood vessels become thicker. So when the wall gets thicker, there is not much space for the blood to flow. As you can see in this cartoon here, like the first circle to your left, the blood vessel is actually very thin, and there's a big lumen there, meaning there's a big space. However, when you have pulmonary hypertension, the blood vessel gets very thick, as you can see in the blood vessel in the circle on the right-hand side panel. But when the wall gets thicker, the space for the blood to flow gets much narrower. So as you can see, as you can imagine, if your kitchen sink is blocked and water cannot drain easily, pressure builds up high. So likewise, when the blood vessel gets narrower and thicker, the pressure within this vessel increases and blood cannot flow easily forward, and pressure in the arteries goes up high. What is the problem? If the pressure in the artery is high, the right side of the heart, that is the one that pumps the blood into the lungs, now has to work really hard to maintain its function, because it needs to pump all the blood that's coming from the body into the lungs to get new oxygen. Now, if the pressure in the artery against which it's pumping is high, then it starts to work harder. So the right side of the heart gets bigger, enlarged, and tries to keep up its function, but beyond a point, it will start to not function well. So it cannot pump pump all the blood into the lungs. So what we then call this as right heart failure. Next slide, please. How does pulmonary hypertension affect the lungs? So like we discussed, the increased pressure in the lung arteries makes it harder for the blood to flow through the lungs and pick up oxygen. So this means, which results in less oxygen getting into the blood and into your body. So patients don't get enough oxygen. Now, the increased pressure and the resistance to the blood flow in the lungs will make the right side of your heart work much harder, leading to enlargement of the heart and eventually failure of the heart, we call as right heart failure. And this, if left untreated, can lead to death. Next slide, please. Pulmonary hypertension is not a very common disease. It affects 1% of the global population. So this is high pressure in the lungs. Now, this high pressure in the lungs can come from many different causes. Like interstitial lung disease, Dr. Kim showed how it's grouped into 3 categories or 3 groups. Pulmonary hypertension is also not one condition. It's a syndrome, meaning it's a category, it's a group of diseases that in common have high pressure in the lung arteries. We group patients with pulmonary hypertension into 5 categories to help doctors, as well as trainees, as well as patients and families to better understand it and treat it. The first category is called pulmonary arterial hypertension. Here, the pressure in the arteries goes up high because there is a problem in the blood vessel itself. There is nothing else wrong. There is some problem in the blood vessels. The blood vessel gets thicker, blood cannot flow easily. The second category is pulmonary hypertension associated with left heart disease. And in this, the problem is because of left heart problem. When the left side of the heart is not contracting or relaxing very well, or if there is a valve that's tight or leaky, then blood can back up into the lungs, and that can make the blood vessels thicker. So this is called pulmonary hypertension due to left heart disease. So the problem starts in the left side of the heart, but then leads to high pressure in the lungs. The third category is the pulmonary hypertension associated with lung disease. So if there is any lung disease, such as interstitial lung disease or COPD, emphysema, or sleep apnea, those lung disease in turn can affect the blood vessels and make the blood vessels narrower. So that is called pulmonary hypertension associated with lung disease. So pulmonary hypertension due to interstitial lung disease will be categorized under this category called Group 3 pulmonary hypertension or pulmonary hypertension associated with lung disease. Then the fourth category is pulmonary hypertension due to blood clots. People can develop blood clots in their legs that can move through the veins through the right side of the heart into the lung arteries. And in the lung arteries, they can block the blood vessels and make the blood vessels narrower so that it's harder for the blood to flow, and that can make the pressure high. So we categorize them as Group 4 or pulmonary hypertension due to obstruction. And then the last category is a category called unclear or multifactorial mechanism, meaning if we doctors are not able to figure out exactly why the pulmonary hypertension, what is the mechanism of the underlying pulmonary hypertension, or if it's due to multiple different reasons, we categorize them as Group 5. So pulmonary hypertension is not one disease state, it's a category. It's like having fever. When you have fever, fever can come from urinary tract infection, it can come from pneumonia, it can come from a toothache, right? So like that, pulmonary hypertension is a category that results from many different diseases. We categorize all these diseases into 5 major groups, and pulmonary hypertension due to lung disease is category 3, and interstitial lung disease related pulmonary hypertension will come under that. Next slide, please. How does ILD progresses to pulmonary hypertension, interstitial lung disease? So in other words, what is the mechanism in which a patient with interstitial lung disease go on to develop this pulmonary hypertension? So as Dr. Kim very nicely alluded, pulmonary fibrosis, lung scarring. That means in which the fibrous tissue scar blocks the movement of oxygen from inside the tiny airspace into the lungs, into the bloodstream. What happens is, as you can see in the middle cartoon, in a healthy blood vessel, the vessel wall is very small, but the red dots, which is the blood, is flowing easily. But in patients with interstitial lung disease, over time, the blood vessel gets much, much thicker. And as you can see, the red dots, which is the blood that's flowing, is very minimal. Blood cannot flow easily. Why does the wall get thick? We as doctors, we have made progress in understanding the mechanism of why it gets thicker, but we still don't know exactly. The top reasons why we believe this happens is, number one, is low oxygen level. When you have scarring and the lungs are not working well, you are not getting enough oxygen. The low oxygen level will make the blood vessel thicker, number one. Two, we also know that there is inflammation. And when there is inflammation, it's like adding fuel to the fire. It makes the blood vessels grow and get thicker. Three, when the interstitial lung disease is so severe and it's destructive, the scarring tissue is so extensive that it starts to actually, in simple terms, eat the blood vessels. There's no blood vessels there for the blood to flow. So those are the three reasons why the vessels gets thicker and narrower so that the blood cannot flow easily. So when that happens, the pressure goes up high and you develop pulmonary hypertension. And if over time that high pressure then affects the heart, the right side of the heart, as we discussed, has to work harder to just push the blood. But so over time it gets enlarged, weakened, and fails. Next slide, please. What we know is when a patient with interstitial lung disease develops pulmonary hypertension, it is associated with worse outcomes. And the reason is now a patient who has a lung disease is starting to have a second problem of heart disease. Needless to say, a lung problem plus a heart problem leads to more poor outcomes than just the lung problem alone. Next slide, please. So both pulmonary hypertension and the interstitial lung disease damages the lungs, and the pulmonary hypertension also affects the heart. So that's why patients who have pulmonary hypertension on top of interstitial lung disease have much reduced life expectancy compared to people who have just interstitial lung disease. That's why it's very important to diagnose this disease early and treat it early so that we can improve the outcomes. Next slide, please. The problem is symptoms of interstitial lung disease and pulmonary hypertension can overlap over time, and it's very difficult. The interstitial lung disease causes shortness of breath and cough. Pulmonary hypertension also causes shortness of breath, and it doesn't necessarily cause cough, but it also causes fatigue, which are very similar to interstitial lung disease. So sometimes it's very difficult to determine whether a patient has developed pulmonary hypertension or not, because one would think that, oh, they are having shortness of breath and they are fatigued because they have interstitial lung disease. But there are certain clues, there are certain specific symptoms which can point more towards development of pulmonary hypertension in patients with lung disease. If the shortness of breath is getting worse, but there is no change in the lung function, either by the pulmonary function tests we do or by CT scan, our antennas should go up thinking, is the patient developing pulmonary hypertension? Two, when the right side of the heart starts to get weaker, patients will start to have dizziness, lightheadedness, sometimes pass out spells or blackout spells. So any of those increasing dizziness, lightheadedness, or pass out spells, especially with exertion, should raise the concern for, is the patient having pulmonary hypertension? Two, when the right side of the heart fails, patients will start to have swelling in their legs or in their belly. So if patients start to notice swelling in their legs or in their abdomen, in their belly, then one should also worry about pulmonary hypertension. And next slide, please. So as we talked, pulmonary hypertension and interstitial lung disease affects the lungs in different ways. Interstitial lung disease forms scars in the lungs. Pulmonary hypertension is due to problems in the blood vessels, but their symptoms can be very similar. So if a patient has an ILD, one should pay close attention to the symptom worsening or an increased oxygen need, because these provides clue to the diagnosis of pulmonary hypertension. So if the clues in a patient with ILD that they may be developing pulmonary hypertension, to summarize again, are they have worsening shortness of breath associated with increased oxygen requirement, but their lung function test does not show any change in their severity of interstitial lung disease, or they start to have dizziness, lightheadedness, or syncope, or pass out spells during exertion, or they start to have swelling in their legs or in their belly. These are clues that they may be developing pulmonary hypertension. And in that case, usually the treating physician will get an ultrasound of the heart as the first step to diagnose this. Next slide, please. How common is pulmonary hypertension? It's a very common question we ask. I think that the truth is there's no one single answer. It depends, the incidence or the prevalence of pulmonary hypertension in patients with lung disease depends on the stage of the disease. So if you focus your attention on the right-hand side panel, these are patients like when you take a patient, or when you look at study patients who have advanced interstitial lung disease, who are referred for lung transplantation, almost 50% of them will have pulmonary hypertension. But on the other hand, if you look at the left-hand side of your panel, in patients who are diagnosed with interstitial lung disease or just in the early stage of the disease, it affects 15% of the people. So 1 in 6 initially will have, but over time, as the interstitial lung disease progresses, 1 in 2 can have or will have pulmonary hypertension. Next slide, please. So if a patient has ILD, being aware of pulmonary hypertension due to interstitial lung disease is important. Why? As once a patient develops pulmonary hypertension, it can impact their life in multiple ways. Number one, because the heart has to now work harder and the blood is not flowing easily through the lungs to get oxygen, there can be an increase in need for the supplemental oxygen. Also, patients who have pulmonary hypertension and right heart failure are at increased risk for more exacerbations of interstitial lung disease. 3, since their heart is also not pumping enough blood and they're not getting enough oxygen, their exercise capacity will decrease even further. And overall, it's also associated with increased mortality, meaning people are at a higher risk of death compared to those who don't have pulmonary hypertension. So it's key to pay attention to these symptoms so that it can be diagnosed and treated early as much as possible. Next slide, please. So it's important to make sure that everyone have a regular checkup and follow-up appointment with their healthcare providers to monitor their ILD disease progression and adjust treatment plan as needed. As so with respect to pulmonary hypertension, patients following up with their ILD clinic every 3 to 6 months according to their needs, according to their healthcare provider recommendation is important, because during these visits, that's what the healthcare provider would look for. How is your breathing? Is your oxygen requirement getting worse? Do you have any signs of right side of the heart getting weaker? In that case, they would be able to do the necessary testing, diagnose pulmonary hypertension sooner. Next slide, please. Next slide, please. I think that's all, and we're happy to take questions.
All right, well, we are back. And we've got a lot of questions from our audience for you guys. That was a really great explanation of some super complicated topics. So I have to just stop and thank you for for your clarity and just making those topics that like I said, are complicated, a lot more accessible for people. So there are a lot of sort of areas that our questions cover. I'm going to try to keep them together, but I may skip around a little bit. About something that several people have asked about, and that is the relationship between blood pressure and pulmonary hypertension. Lots of people out there have hypertension or high blood pressure, and there's some questions from several people about, are those things related? How are they measured the same way? I'll ask you, Dr. Thanapan, to start with that.
No, I think it's a great question. and it's a big confusion. So the regular blood pressure we have, like when you go to your doctor's office, they put a cuff on your arm and check a blood pressure, right? So that's the regular blood pressure in the body. The pulmonary hypertension is the blood pressure within your lung arteries. So that is completely, these are two different things. So regular blood pressure is called systemic hypertension or essential hypertension. And it's easy to diagnose because the doctor can put a cuff and measure. Whereas this pulmonary hypertension, which is within the lungs, is difficult to diagnose because you cannot put a cuff inside the lungs to measure it. So the first clue for a doctor to know whether the pressure in the lungs is high or not is by doing an ultrasound of the heart called an echocardiogram. So when we suspect pulmonary hypertension, we do this test called echocardiogram, and they look at the right side of the heart, and in the right side of the heart, they can estimate the pressure inside the lungs. And if it's completely normal, good news. But if it's not normal, that suggests that the pressure can be high. But echocardiogram is still not a confirmatory test. One cannot be 100% certain. So if the echocardiogram is abnormal, then we will do a procedure called right heart catheterization. It's an invasive procedure, but not a major surgery. By under local anesthesia, we find the vein in the right side of your neck or left side of your neck, or sometimes even the groin. And we, after giving numbing anesthesia and finding the vein, we put a needle in the vein, and through that needle, we take a wire through the needle into the right side of the heart and into the lungs and actually measure the pressure. And this is called right heart catheterization, and that's the gold standard for diagnosing pulmonary hypertension.
That's great. Thank you. I think that helps a lot to understand the differences between those two topics. Dr. Kim, I'm going to go to you next and ask you to talk a little bit about risk factors for the development of pulmonary hypertension in the setting of ILD, and maybe break that up into both risk factors that are related to the lungs or the lung process itself, or are there others that are maybe external to the lungs that have to do with more of the rest of the body's health or environment?
That's a great question, and it's sort of a complicated question. So PH-ILD, pulmonary hypertension in patients with ILD, as you've all learned, is a complicated process and can really impact quality of life and sometimes prognosis. There are some things that we pay attention to when we see ILD patients. For example, when we see patients with autoimmune diseases like rheumatoid arthritis, lupus, scleroderma, we are especially cognizant of the fact that they have a double risk factor for developing pulmonary hypertension. One is the autoimmunity itself, and secondly, it's the interstitial lung disease. So we pay attention to all our patients, but we do think of the autoimmune people as having sort of a double whammy or two risk factors for developing pulmonary hypertension. In terms of other risk factors, one is low oxygen levels. You know, people who come to our clinic usually have a test to measure their oxygen levels, both at rest and with walking, and that's a 6-minute walk test. Many of you have had that or will have that in your clinics. Why do we do this? So we do this to check oxygen levels because sometimes people will have low oxygen levels during walking or exertion and not be aware of it. Most people who drop their oxygen level to a low level can feel it. They feel short of breath, or sometimes it makes them cough more, but there are people who don't necessarily feel it. And patients sometimes ask me, so why does it matter if my oxygen level is low? And this is why, as Dr. Therapen knows, low oxygen levels are really bad for the lungs, especially the blood vessels in the lungs. It increases the risk that those blood vessels will get damaged, leading to pulmonary hypertension. So that's another risk factor, is low oxygen levels. There are certain medications that increase risk to get pulmonary hypertension. They're not as widely used. You all might be aware this was a number of years ago. Some of the diet supplements like fen-phen, these were medications designed to help people lose weight, but they were associated with an increased risk of pulmonary hypertension. So those are sort of the risk factors we think about. And in terms of, can you do anything to mitigate those risk factors? I tell my patients, you know, it's important in general just to live your life, maintain your activity, spend time with your friends and loved ones, pursue your hobbies, and then protect your lungs. Make sure you're getting the oxygen levels that you need, avoid exposures. The only thing that should be going into your lungs is clean air. No dust, no fumes, no smoke, no chemicals, no mold spores. That is my simple question to a very my simple answer to a complicated question.
Thank you. That was a great explanation and overview of a lot of complicated risk factors. Dr. Thanapan, I'm going to go to you next and ask you to talk a little bit. You showed the 5 groups of types of pulmonary hypertension, the WHO groups, we would say. It wasn't on the slide, but that's how we refer to them. Can you talk about whether there might be overlap between the groups? For example, could somebody with interstitial lung disease that has pulmonary hypertension also have a contribution if they have, let's say, thromboembolic disease or blood clots in the lungs? Could that contribute to that as well?
Yeah. Thank you, Dr. Case. I think that's a great question. So we have this classification system, or simple terms. We have these 5 buckets, and we try to categorize each disease state, or we try to categorize each patient into any of those 5 classifications. In an ideal, real world experience, that's not always possible, right? We humans are not like textbooks. Like, we have many things overlapping. So you're absolutely right. In majority of the cases, let's say if you take a patient with interstitial lung disease, and majority of the time their pulmonary hypertension is due to their lung disease. But they can also have some left heart disease. They have had high blood pressure and diabetes over time, and they have had heart attacks that affects the left side of the heart. So their left heart problem can also contribute to pulmonary hypertension. Like you said, like they might have had blood clots, because when they have interstitial lung disease, they are not very active, or they're not able to be very active because of the disease. So they develop blood clots, and when they develop blood clots, that also adds to pulmonary hypertension. So that's very, very important point, that pulmonary hypertension is a syndrome. It can come from many things. The 5 categories we do is not a perfect method. A patient can fit into any of these 3 categories, or many categories. So when we see patients, what we do is, first question is we find out is whether they have pulmonary hypertension or not. Then, we do a panel of testing. We just never assume that if a patient has ILD, the pulmonary hypertension is coming from ILD. We do a panel of tests to be comprehensive and thorough, to see what are all the reasons in that particular patient the pulmonary hypertension is coming from. And then I think that's very important, because the treatment then is targeted towards the underlying problems. If they just have interstitial lung disease, pulmonary hypertension, we treat that. But if they also have left heart disease, then we focus and treat the underlying left heart problem. And if they have blood clots, we treat the blood clots.
That's great. Thank you. Okay, we are getting short on time, but I would like to try to get in 2 more questions if we can. Dr. Kim, I'm going to go to you next and ask, in a disease process like ILD, which tends to be progressive in lots of people, how do you differentiate? I mean, we saw that sort of pictorial representation of the escalating symptoms that can overlap when pulmonary hypertension develops. How do you how do you try to tease that out clinically? I know Dr. Thenipan mentioned an echocardiogram, a right heart catheterization. Are there other clues that you might use to differentiate whether this is more underlying disease progression or development of a new problem like pulmonary hypertension?
That's a really good question. This is something we face in ILD clinic all the time, because we know that ILD can get worse if it's not responding to treatment, or sometimes we don't have treatment. So in terms of how do we differentiate, is it the ILD causing worsening symptoms, or is it something new like pulmonary hypertension? So one of the clues we have might be from the pulmonary function test. And, I know my patients hate doing the PFT. It makes them cough. They don't feel good. It's exhausting. But this is one of the reasons we get the PFT is it helps us because there's one test in the PFT, the DLCO, the diffusing capacity. And what we look at is in someone who's not doing well, we look at the full pulmonary function test, and we specifically look at that DLCO number. If that's dropping, but the rest of the lung function test numbers are not dropping, that could be a hint that that person is developing pulmonary hypertension. The other thing we might get is a CAT scan of the lungs, a high resolution CAT scan of the lungs, because if that shows that the pulmonary lung disease, the interstitial lung disease, is not changing, that increases our suspicion that the symptoms are might be caused by new pulmonary hypertension. So those are a couple of things that we look at. And then Dr. Thenipan uses the 6-minute walk test frequently. It's one of the tests for pulmonary hypertension. We also use the 6-minute walk test in ILD clinic, and we look at that, what we call oxygen desaturation. How much is the oxygen level dropping? And if it's dropping much lower than before, we also think about maybe this is pulmonary hypertension causing that. So those are just some of the things that we try to tease out and investigate in ILD clinic.
That's great. Thank you. It's really helpful for people as they're thinking about their own journey in this. Okay, so one last question. I haven't left a lot of time, but Dr. Thenipan, I did want to ask, is there any ongoing research into pulmonary hypertension related to ILD?
No, great question, and this is an active area of research. As Dr. Kim said, our knowledge has significantly and has gotten enriched in the last 20 years. I think there is more hope for this disease compared to a decade ago. Multiple pathways are being evaluated and studied to target specifically the pulmonary hypertension due to interstitial lung disease. And as many of you may know, there was a drug that was just approved by the FDA in 2021 to treat this condition specifically. So 10 years ago, when we started our program, we never had any therapies, and it was oxygen and water pills, and if things get worse, we have to send patients for lung transplant. But we have now an approved therapy that has shown to improve patient symptoms, quality of life, and reduce hospitalization. And like that, there are many other drugs that are being studied. I don't want to just name one or two, but this is an active area of research. Multiple pathways are looked at, and I'm very hopeful. I think I can see the light at the end of the tunnel.
That's a great note to end on. Thank you so much. I just want to thank you both again for a wonderful presentation, for answering so many of our questions. I'm sorry to those who I could not get to. We had so much engagement and interest in this topic. But before we close today, I would like to just go over two more housekeeping things. When this program ends, there will be an opportunity to give us feedback. So if you can stay for just a moment for a quick survey, we would love to get that feedback from you. And then we will have a recording of this webinar that we'll post to our website at pulmonaryfibrosis.org when it is ready and up and posted. So that will probably be in a couple of weeks. Thank you all again for attending our industry-sponsored webinar presented by United Therapeutics and the Pulmonary Fibrosis Foundation. And I hope you guys all have a wonderful rest of your day. Thanks so much.